Well, it's an honor to be here, to be invited to the first Congress, and to the leadership of the EAS. I want to congratulate you for pulling this off, and it's always difficult to do the first of anything, really, and so to do it well is really exciting to see. I'm here today to talk to you about research opportunities in clear aligners, and before I do that, I want to first have some disclosures. I used to work for Invisalign. Today, I'm a consultant for Invisalign, and I still own shares of Align Technology stock. Now, when I was in high school, I was a high school student. Every summer, my parents would take me and my brother to the national park called Yosemite. Some of you, in fact, may have been to Yosemite before. It's beautiful, right? You have mountains and waterfalls, and it's known for its half dome, the famous half dome. You see the logo up there on the top. And there's a waterfall that you can climb to. It's called Nevada Falls. And we would go up this to the top of the waterfall every year, every summer. And what's interesting about Nevada Falls is that there are actually two ways to get to the top. The first way is to take this green path. And the second way is to take this yellow path. Both of them end up at the same place at the end. But what's interesting about this trail, this hiking trail, is that the green path, which is called the John Muir Trail, is named after a famous environmentalist. It takes about 4 miles to walk to get to the top. And along the way, you will see a dirt path that you climb up, and it's a very gradual ascent to the top. You will see trees, and you can see the mountains in the distance. Very, very lovely. The other trail that you could take, the yellow path, is different because it is a shorter path. In fact, it only takes 3 miles to get to the top, but you pay the price. And any of you who have ever actually gone to Yosemite and done this trail know that the price you pay is that there is a very steep ascent to get there, and you are very tired. There are steps that have been carved into the mountainside that you walk up, and this is an interesting trail because then at the top or halfway there, you will end up with this view. It is the view of the lower waterfall called Vernal Fall, and it's been very beautiful, very breathtaking. So why am I sharing with you about hiking at an orthodontic conference? What is this all about? Well, obviously, some of you have already made the connection that if we're talking about two paths to the same place, if these paths represent different ways of treatment, whether it be braces with aligners or one system of aligners to another system of aligners, then there must be a way, a scientific way for us to determine, well, what is the way to follow? What are the advantages and disadvantages? How do we measure what is the path that we ought to take when we make clinical decisions? And if we follow an evidence-based approach to clinical decision making, we follow this pyramid, right? All of us are very familiar with this pyramid. And at the top of this pyramid is the strongest evidence. It's the randomized controlled double-blind study. And at the bottom is opinion. Hey, you should take this path. This path is better because I say so, right? Well, a little bit of history here. So I was preparing for this presentation and went on to Google to say, hey, I wonder what has happened in the past year regarding Clear Aligner Orthodontics. So I typed it in, got a search result back on Google Scholar, and I was very encouraged. There was 140 results. Wow, that's a lot. A lot of things have happened in just 1 year. So I looked at the results, kind of skimmed through it, say what's in there, and this one caught my attention. It was on the first page, Clear Aligners for Orthodontic Treatment. Results, 11 studies, 480 patients, 2 randomized trials, 5 prospective studies. Oh, hey, this is interesting. Maybe I could talk about this. And then so I clicked the link, and it said Clear Aligners for Orthodontic Treatment, and it said the quality level of the studies was not sufficient to draw any evidence-based conclusions. And furthermore, I realized this was actually a review article of another article, which Dr. Wheeler had mentioned earlier, and I said, this name looks so familiar. Where do I know this name? Oh my goodness, this was the doctor who invited me to come speak to the EAS, and it was very discouraging. It's like, what am I going to talk about? What am I going to say? And so there was a little bit of a dilemma for me in trying to decide what am I going to talk to you about. And a little bit about my background is that you heard that I used to work for Invisalign, and I left in 2013. And After 2013, I found myself with a lot of time on my hands. I mean, I had my practice in San Francisco, but that was a part-time practice. And I was talking to some friends about what I would do with my time, and my friends encouraged me, actually, don't jump back into full-time practice right away. This is a beautiful opportunity for you to try to explore different things, get some hobbies, learn something different. And so I took that advice, and the advice that I took was to go and learn something different, learn a new skill. And so I took some classes, and one of the classes that really caught my attention was a class on something called coaching and leadership coaching. I don't know if you are very familiar with this field, but as professionals, we're used to consultants. And a consultant you can hire, and they'll come into your office, and they'll tell you what you need to do. You have so many patient no-shows, here's what you need to do. You have problems with compliance, here's what you need to do. But a coach is different. What a coach does is, it says, okay, they ask you questions to get you to think about the problem, but to approach the problem in a different way. The coach actually does not offer suggestions, but the suggestions actually come from yourself as you start to think about what the problem is and where you're stuck, and they help you get unstuck. And it was a very different idea for me that really attracted me. And so I'm in the process right now of taking more coaching classes, and there's an International Coaching Federation certification. I'm actually in the process of trying to get certified for that. And I found myself in this dilemma of, well, if the top of the pyramid, we're not there yet, and we don't want to rely on public or personal opinion, I tried to coach myself through creating this presentation for you and asking, if I was a coach that I hired, what would I say to myself and what kind of questions would I ask? And the first question I asked was, well, what is it that we're trying to understand about clear aligners and clear aligner treatment? And I found myself saying, well, if I'm trying to understand something about clear aligner treatment, this is what I'm trying to understand, ultimately, is how do I successfully treat these types of patients? It shouldn't be any surprise, teens, adults, class 1, 2, 3, the whole spectrum, right? But the question is, what does that look like? So what I did was I mapped out the orthodontic spectrum that you just saw earlier in a visual way. And at the top of the chart, you see teens in the red box, adults in the bottom box, and they're symmetrical. But I split them apart because anyone who's done aligner treatment knows that you can't treat teens the same way as you treat adults. Now, you have teens, and then teens that are class 1, class 2, or class 3. Those are your 3 branches. And then underneath that, you have your overbite. You have normal overbite, deep bite, open bite, right? And underneath that, you have crowding and spacing. And when you visualize the whole universe of orthodontic malocclusion, not the whole, but a lot of it, most of it, you see that there's 36 boxes of orange underneath. Which means that if we were to do prospective clinical trials, because of the subtle differences in each of these different types of malocclusions and the influence that these factors have on each other, overjet may affect how you treat crowding, vertical may affect how you treat sagittal, so on and so forth. Really, to understand what's going on, you would have to have 36 different studies, which is quite a lot of energy and effort. And I don't know if it's realistic to expect that this will happen anytime soon. Now, to make things worse, orthodontic malocclusion is not a symmetric distribution. What I mean by that is some types of malocclusion actually are more common than others. And so once we scale for the fact that open bites happen less than normal overbites, class 3s happen less than class 2s, the sizes of the boxes also change as well. You can see, and I estimated, these are not actual accurate representations, but the idea here is, on top of the fact that you have so many different types of malocclusion, you also have the problem of size and recruiting concerns if you're trying to do research. So, for example, you have a patient here, crowding, class 1, in a teenager. Well, there's a lot of those, but the problem is those of us who do aligners on a regular basis don't really have a problem doing aligners on patients like this, right? It's like, okay, that's very routine for us. And in order to detect small changes in the way we approach these types of treatments, because the changes are so small, things like, well, where did you position the attachment? What type of shape of attachment did you use? What kind of IPR did you use? Did you use any IPR? What kind of material did you use? In order to detect those changes, you would actually have to have a very, very large sample size in your study in order to have any significant ability to read over the noise. Okay? The other problem is, well, if you have a more complicated treatment like this adult class 2 open bite, where are you going to get your patient pool from? Do you have that many patients of this type in one university or one practice to be able to figure out, okay, let's run a prospective study to study that? So there are some inherent challenges with trying to study this many types of malocclusions using a device that is sensitive to the type of malocclusion you're trying to treat. And so what we have here is what I call I don't call it, but it's a long tail distribution problem where at the front end of the distribution, at the head of the curve, you have a whole bunch of these types of malocclusions, or a few types of malocclusions, but you have a whole lot of patients of them. And then at the tail, you have a whole bunch of different types, but there aren't so many of them. Okay. Now, no one's really concerned, at least that I know of how do you treat basic crowding types of cases. And so the studies, as I see it, would really have to be very specific, very focused, very detailed, and then given the technology changes that happen so quickly, once a year, new changes come out, there's also the challenge of, well, how relevant is the findings once you come up with your study and finish it out? This is a patient that came to me, we treated her in 12 months. So it is what we call now an everyday aligner type of treatment. No braces, no auxiliaries were needed to treat this. And so if we were to do studies to try to figure out how to improve this, I think you'd have to focus on the details and you'd have to be very clear as to what your goals were, and hopefully your sample size is big enough, it might be hundreds, it might be thousands, to be able to detect, oh yes, by changing that attachment shape by so much, you were able to improve. And so I'm not sure a prospective study is necessarily the best way. Maybe modeling, maybe a single tooth model, maybe that's a more effective way of determining the influence of these subtle changes. On the other hand, you have patients like this. This patient came to see me. She had been treated as a child with orthodontics. Adult patient, female. She's congenitally missing 2 teeth in the lower, had 2 teeth taken out, and then over time, she noticed her bite was opening up again, and so she found me. I had treated a friend of hers, I believe. She wanted to know what I could do to help her. And I looked at this and I said, wow, I've never treated anyone like this before. And so I had heard of, and to make things worse, we took x-rays just to see what was going on, and she had actually significant root resorption from the previous orthodontic treatment. So that also then limited our options, right? So I actually said, you know what, I had recently gone to a seminar at the University of Pacific. I heard a doctor talk about surgical treatments with aligners where you didn't need to put braces on the patient in order to do the surgery. And that was kind of spinning through my head at the time, and I was pretty excited. So I told her about this option. I said, well, we could think about that, but I've never done that before. So why don't you go and ask different people in San Francisco what they thought, and come back and we can talk if you didn't find something you liked. So she got 5 different opinions. Okay. The first option was her general dentist, and the general dentist says, oh, you don't need braces. You have root resorption. You don't want to go through that. We'll just put some crowns on you and get your vertical dimension down, and you might need a few root canals, but it'll work, and we'll close your bite that way. Second opinion she went to was another orthodontist, and the orthodontist said, we can do this with Invisalign, but we can put TADs in there to avoid the surgery. We'll intrude the posterior teeth. It'll be great. But the problem is it'll take 2.5 years, and we can only get you 80% of the way there. The third doctor she went to was the oral surgeon, because I had recommended surgery. And the oral surgeon said, oh, yeah, we can close your bite. You actually don't have a whole lot of alignment problems. You might need braces afterwards, but we can just close the bite, and you might not need braces at all. It could be better with braces. She goes to another doctor, orthodontist, says, definitely the surgeon's right. Get surgery, close up the bite, and then I'll put brackets and wires on you afterwards. And then the fifth doctor was me. I said, you know what, I went to this lecture, and it's an interesting idea. What about getting the surgery, and then we'll do Invisalign afterwards? Now, in reality, I actually saw her first, and I put myself last to just to tell the story better, I think. But I was hoping in some way that she would actually pick someone else, just because, who wants to be the first one to do something different? I'm not going to be a hero. And so what's interesting is that you have these 5 different ways, and are there 5 different papers out there that have done the evidence-based type of approach so that I could go and decide which way to go? Have all these other doctors done the research and based their decision on this approach? And I would say probably not. They based it on what they're familiar with and what they're good at, right? And therein lies also the problem of how do you do a study that's prospective double-blind? You just recruit a bunch of, let's assume you could get a bunch of skeletal open bite patients recruited. Hey, guess what? Our university is in a city that has a whole family of 100 people that all have the same skeletal open bite, and we're going to randomly assign them to one of these 5 groups. Congratulations, you get crowns. Okay, of course we're not going to do that. That's not really going to happen, right? And I saw this email that came to me at the end of the year, last year, and it sort of confirmed what I was thinking. This was an invitation to participate in the practice-based research network, and it's a study on anterior open bite in adults, and the way they're structuring this study is it's going to be a 3.5-year prospective study of 840 patients and 210 providers. And it sort of reinforced in my mind that it makes sense that they have to spread this thing out over a whole bunch of different doctors because, well, number one, it helps you get the methodology spread out over different clinicians. But second of all, there is this problem of when you're at the tail of the distribution, you have case types that are much more rare, right? And so then the question becomes, well, we have some inherent problems in trying to understand how to treat more difficult cases with aligners using the traditional methods of research. And so I found myself asking, well, so then what do we do to move forward? How do we tackle this problem? If I was a consultant to try to fix this problem, here's what I would consult. Well, then you just need to be more creative in how you design your study. Something like the practice-based research network, that's another approach to solve the problem. Or as a consultant, I would say, well, the problem is you need to be more clever in your design of the study so that your sample size can be smaller yet still have a high power. Or I would say, we just need more money. 36 studies, no problem. 1 million euros apiece. Give me 36 million euros and I will solve that problem for you. And the problem is just a matter of how do I raise more money. And when I was at Invisalign, actually, that's kind of how I thought. I look back and we did some really fun things and really some interesting things there. And I look back, and one of the things that we did at Invisalign that was very exciting, and I'm glad we did it, was we created the Align Research Awards program. Dr. Tim Wheeler was very instrumental in setting this up. He helped guide us in terms of how do we structure research awards from a company in order to have it fund scientific research in a way that is objective, fair, and solves problems that clinicians want to solve. And that program continues today, and it's very exciting. But still, that is trying to attack the problem from a head-on approach, right? And so as I thought through the problem, I asked, well, what does moving forward mean to us as clinicians? And so I came up with this list of what am I looking for? What am I trying to understand? And here's what I'm trying to look for. Basically, I want to know is, can I offer my patient some treatment options that are reasonable and realistic, that we'll actually get to the result or pretty close to the result? And then are there bad ideas? Tell me what those bad ideas are, okay? Has someone else already done this before? It's always great to see the pioneers lead the way and say, oh yeah, I've done one of those in the past. And ideally, it's not just one doctor. There's always that lecture you go to, right, where it's like, wow, those are really wonderful cases, but too bad you're the only doctor on the planet that can actually accomplish those results, right? So if I could see 5 people, 10 people, 20 people, that's even better. Now this one here is really important. What did you actually do to get the results you did? This is probably one of the weaknesses of the prospective trial, is that a lot of times the prospective trials, they give you the numbers at the end, but they don't really tell you all the important details of how they actually got to the end. So you read the data and you say, wow, that's really strong, the data's really strong, but I have no idea how to reproduce what was published in that journal on my own patients. And with aligner treatment, it's very important. What attachments did you use? When did you put them on? What type of material did you use? Timing of IPR, what did you use auxiliaries? How did you put the auxiliaries on? What configuration did you use? How long? The list goes on and on and on and on, and they're very important. And so how do I replicate the recipe that you were successful with? That I would like to know. And whatever you do with research should tell me that. And then finally, what should I tell my patient? Is this a high probability of success, low probability? How good of an outcome can we expect? So ultimately, the research should give us these types of answers. So are there other ways then to get that information? I mean, where else can we go if we're waiting for trials to finish so that we can move forward? So I go back to the internet. It's interesting. We live in an information-rich time. And you can search on the internet now for cases, and this is interesting. So coming from the industry before, one of the challenges that the profession has, I think, is that because of the long time it takes to get a publication out, I think a lot of the manufacturers they're taking things into their own hands, not because they don't want to go through the publications, but because they're anxious to get it out there to a lot of people. And so as a result, companies are essentially publishing themselves and using the internet as a vehicle to accomplish this. And so some journals have realized this, and they're also being proactive about, well, how do we solve this problem, right? And so I don't want to get into this problem, but just kind of pointing out this is how it's going. And so if you go online, you can basically say, okay, where can I find cases online to help me learn? This is a journal in the US. It's a Clear Aligner journal, and they have something called a case of the month. So every month you get a case, and you see the details of what they did before and after. And you're sort of hoping that one of their cases is something that you want to treat. Here's another internet website from another aligner company. This one's actually a spring aligner company, so it's not really a clear aligner company, but they also do the same thing, case of the month. And then, of course, Invisalign has a new website that's been revamped. It's called Invisalign Gallery, and they also have a case of the month. And on top of their case of the month, they also have a library of other cases that were successfully treated, which is several hundred, actually, on this website. And many of you are probably on there, in fact, but this is a trend. I was the editor for the US version, or the North America version, of a case gallery, but we didn't do it online. We sort of did it what we call old school. we printed a book, a physical book, and we did it I was editor for 5 years, and the 2010, 2012, and 2014 were cases that were submitted from orthodontists, and then 2011 and 2013 were cases that were submitted from general dentists. But what's interesting about being able to do something like this is that you now also have the ability to look at cases and see what happens over time. And the time factor is actually kind of interesting because we have technology that is rapidly evolving. And so the question is, well, what can we gain from having a whole bunch of cases around on the internet, cases perhaps even from studies that are case studies published in journals like JCO? And this is where it gets kind of interesting. So what I did for the presentation was I basically went onto the Invisalign Gallery because I had access to these books and simply just going to Microsoft Excel and marking down what I saw. And you can look then between 2010, 2012, and 2014 of the 261 patients that were in this collection, you can see what the changes were over time. And so this is a small sample size, but it's to illustrate a point. I'm talking about research opportunities, and so all that I present to you as a methodology can be reproduced by those people who are interested in seeing more specifics about the case types that they're interested in, that you're interested in. So think of this as a model, as a roadmap to get more information to help you make decisions in clinical practice. So what's interesting about the distribution is that in 2010, if you look at the blue line, it's pretty flat around the teenage to young adult age. We'll call the 30s and 40s young adults, okay? Let's just do that. And then 2012 and 2014, the green and the red line, you can see that there's a shift towards teenagers. Now, remember this is a biased sample because Invisalign actually encouraged doctors to send in successful treated cases of teens in the year 2012. And so as a result, doctors said, oh yeah, I've got a bunch of teens that you can see, so they would actually send it in. Totally biased, but you got to remember, if they didn't have successfully treated cases anyways, it doesn't matter what Invisalign asked for. You know, they could have asked for successfully treated orthodontic cases of penguins, and it doesn't matter if no one treated penguins. Why would it matter to, you wouldn't see it in the data. So just keep that in mind. It's biased data, but it's important to see that it was possible to do. Because possibility gives other people a sense of, hey, someone else did it. I can do that. And so we can then look at sagittal distribution. We can see that, for example, between 2010, 2012, 2014, there's a decrease in the number of class 1s in this collection of 261 cases, but there's an increase in the collection of class 2s. Again, biased sample, Invisalign actually said to the doctors, hey, send in class 2 successfully treated cases. We'd be interested in publishing it, and so that's what happened. But now this is exciting because as someone who's interested in trying to treat class 2s, I could go in there and dig out those class 2s and say, what actually happened? What did they do? What was the magic formula that these doctors used? Vertical distribution, same thing. The reduction in the nominal overbite over the years, the increase in the open bite, again, because doctors were invited to send in successfully treated open bite cases. So this is encouraging because it tells me that the world of what is possible is growing. And you've seen, I was really impressed earlier on when I saw some of those open bite treatments. It's like, wow, that's great. Okay? Now what we can also do is then dig into the details because details are very important. We could look at how long the treatment times were. We could look at how many aligners were there. We can look at how many refinements were used. Interestingly enough, the refinement rate was around 75% in 2010. It slowly decreased, but it's still up to 69% by 2014 for these successfully treated cases. So the successfully treated cases involve kind of a lot of refinement. But apparently these doctors sort of figured out that it's not a big deal. Maybe they use scanner technology, but it helps me as a clinician set expectations for my patient that, in order to be successful, guess what? We're going to have to do refinements on these cases. Now, one interesting thing is that the treatment time and number of aligners actually have some kind of relationship that I had to think through because the average treatment time was more or less flat over the years in these successfully treated cases, but the number of aligners is going up. Now, how is it possible that the treatment time is more or less staying the same, but the number of aligners is going up? This might be something that someone out here, one of your students or yourself, if you're interested, you could study and try to figure out what's going on there. And I have a suspicion that the doctors are altering the interval of change. Maybe during refinement, instead of going 2 weeks for each aligner, they're just going to 10 days or 1 week. Because that's the only logical explanation is, well, what happened? How did you get the same amount of treatment time, but a lot more aligners? And that's something interesting that may be worth looking into. We can use this type of data then to look at patterns of treatment. We can look at extraction versus non-extraction. We can see if there's any difference in terms of treatment time. We can look at, right off the bat, we have 38 sample size of extraction cases. We can look to see what kind of problems were experienced because success is a very vague term. It's like, well, there's still problems with those cases. Well, let's go look and see what kind of common problems we see. Are there rotational problems? Are there vertical problems still remaining? Is it a full correction of a class 2, right? Look at treatment time with respect to different extraction patterns. For example, I was able to statistically find a difference between non-extraction and extraction, but really to do this truly as a study of apples-to-apples comparison, we would then need to go and see, well, let's compare class 2 extraction versus class 2 non-extraction. Let's look at class 1 extraction versus class 1 extraction. Don't want to confuse you here. Okay? But again, ideas, this is research opportunities, is to use aggregate case collection data as a means to quantify what kind of expectations might be realistic as a best case scenario. And then we could look at why is it that 1 or 2 bicuspid extraction cases had the highest treatment time? That's kind of strange compared to 4 bicuspid extractions. Is it because maybe we only usually do 1 or 2 bicuspid extractions when we treat class 2s and we try to camouflage? And so does that have an influence in terms of why the treatment time is so long? Because usually for 4 bicuspids, maybe we have a lot of crowding, and so that could be a possible hypothesis. So that would be worth looking into if you are so inclined. And where I found the most interest in this approach was then to look at the recipe which allowed the doctors to be successful. You know, in all walks of life, the best way to emulate success is to figure out who has been successful in the past and go do what they're doing. If it's dentistry, who are the successful dentists? Let's go figure out what they're doing. If it's sports, what are the sports players doing what's their technique that they're doing that allows them to have the edge? In business, who's investing in what? Let's go follow them. And so these are successful treatments. What are they doing that I can learn about? And what you see is interesting is that out of these 261 cases, the use of auxiliaries has grown over time. This idea of hybridization that we just heard about, that was a new term that I had not heard before. The use of elastics has gone from 33 to 50 to 71%. The use of buttons has gone from 20 to 37 to 53%. So are you using buttons and elastics in your aligner treatments? Maybe. If not, then you might want to think about it, because successful doctors are, in their cases, using these as part of the treatment. Now, what's also interesting is you can also see that, well, what about braces? Well, it turns out that in these cases, the use of sectional appliances more or less stayed flat. So even though the cases have gotten more complex, they haven't necessarily had to resort to braces in order to get to the end, which is, I think, kind of encouraging. But you do see other things like bite correctors, jaw surgery, TADs, a couple expanders in there, even headgear. So, this is the combination that doctors are using in order to get the final result. So, very encouraging to have an approach to see what the recipe for success looks like. So then I go back to my case. Well, then how can I use this approach more specifically? Right? Because 261 cases is all over the board. It represents all sorts of malocclusions from class 1 to class 3, open bite to deep bite, crowding to spacing. It's aggregate data. I'm concerned about what? Adult, class 2 open bites. Let's just take open bites. Let's keep it even more focused, more broader than that. So how do I treat open bites? And we saw a wonderful presentation earlier on open bites, and it's like, wow, great timing, So what I did for this exercise for you was to go onto the Invisalign gallery website, and because they have hundreds of cases on there, they put together something called filters. And so you can say, well, show me out of your hundreds of cases, show me your open bite cases. So I applied the filter, and 65 open bite cases showed up. It's like, wow, there you go, instant sample to play around with, okay? Let's see what they did. Now, 65 was too much to analyze, so what I did was I said, just give me the moderate and severe open bite cases. And so then I pulled from that the subset of moderate to severe open bites. And then I also had these books that came out, so I went and said, okay, which ones are the moderate to severe open bites there, and let's see what kind of sample size we can have, and maybe we can come up with some patterns. And so what do we end up having for this mini study? It's not really a study, but I wanted to give you an example to show you that it is a feasible roadmap. So I had 10 moderate to severe open bites from the website from all around the world, and 23 moderate to severe open bites from the 2 publications that I shared with you earlier. So I had a total sample size of 33. And these are the ones that came from the website. And it's interesting. You see names of pioneers in clear aligner orthodontics, people who have been bold and had ideas and understood biomechanics and used aligners in connection with their special expertise and were able to successfully achieve outcomes. Dr. Garino, look, your name is out there, exciting. And so these were from the website, and these were from the US and Canada. And did I really need to show you all 33 cases? And the answer is yes. You know why? Because there's some power in seeing, wow, these are really open bites. And we're not talking about, reduction of 2 millimeters or 3 millimeters. These are pretty impressive corrections of open bites. And so we need to see this not only to recognize the doctors who've successfully done this, but visually it helps us then to say, well, am I treating something that is represented by these cases here? So there was 33 of them, and what we can do is then we can look to see, well, what are the differences in this group compared to the main group? You know what's interesting? I found that most of these open bite treatments of the 33 were, like 82% were female patients, whereas the total 261 patients was like 2/3 female, 1/3 male. And so someone can go and study, why is it that there are more female open bite patients in the sample? Is it something related to the condyle and, I don't know, hormones or something? Or is it that men just don't care and so their open bites just look okay to them? I don't know the answer, okay? But there's something interesting possibly there, you know? There were more class 1s in the open bite sample than there were in the main distribution, and less class 2s, which I sort of explained that, you know, these doctors who treated these open bites are smart. They realized that let's select cases where I can fix the open bite and not have to then also deal with the complexity of treating something else. And so maybe they were carefully picking when to apply clear aligners to the correction of open bites. That's a possibility. And then the crowding and spacing distribution was more or less the same. And then I went and said, well, is there anything special I should watch out for in terms of treatment time, refinement use, the number of aligners, auxiliaries? And there was nothing I could find. It was basically the same as the other successful cases, more or less. So which is good. It tells me that there's nothing especially more inherently challenging than the other treatments. But what I wanted to pay attention to was, well, what are the doctors doing in the formula? And so if we look at the auxiliaries, this is where I thought it was kind of interesting. Again, guess what shows up at the top? Buttons and elastics. Because 58% of the open bites in the 33 cases had some kind of auxiliaries associated with it. So buttons and elastics and a bunch of TADs were used. And that's interesting. TADs for open bites? What's going on there? And then at the bottom, we have cases of 1 or 2. Not that these are not successful, it's just that they haven't caught on yet. Okay, there was a case in there from Dr. Takamoto in Washington. He did this thing that was really interesting. He put an S6 appliance on top of his aligners, and you can see this case online, but he put his S6 aligner on top of his aligners, and he was able to close the open bite with this extra appliance. Now, could this eventually be the standard for how open bites are treated? It's possible, but it just hasn't caught on yet, and so we'll just have to wait and see. So just because you're not in this pool doesn't mean that it's not a possible treatment, it's just that it hasn't really become popular yet. And I would argue that actually prospective studies are not the best way to figure out what is possible anyways. You don't want to go and start a 100-patient study on 5 possible ways, not really sure if any of them will work out, because then you have 100 patients that you have to finish, and you're stuck taking care of all of those, right? So really, it's much better, in my opinion, to have doctors try it 1, 2, see how it works, and then present it to other doctors, and if it makes sense and it catches on, then you'll have a bigger sample size. Okay, so let's dig in a little bit deeper into then what were doctors doing with these TADs and elastics? What's that all about? Turns out that they were doing something called sling elastics and TADs. There were 6 cases in there, and they all were using slings and TADs, sling elastics and TADs. What's that? Okay, it was a vertical correction where they would put TADs in the buccal and the lingual, put the aligner on top, and then the patient would run a short elastic connecting the TADs together, and that would intrude the posterior segment, cause the mandible to auto-rotate forward. Like, wow, that's clever. And I remembered actually that in 2012, I was it's my job. So I was the MC for a Invisalign Summit conference, and it was my job to introduce the 4 presenters on stage. And one of the presenters was Dr. Tabakman out of Texas, and he showed a case of slings and TADs with his open bite correction, and you can see that it was a severe open bite, and he was able to intrude the posterior segments and got the bite to close. And coincidentally, just a few weeks into the past year, I was invited to go to USC and talk to the residents about what's going on with clear aligners. And one of the associate professors there, name of Dr. Dougherty, said, hey, you should take a look at my upcoming publication in the PCSO journal. I said, why? He's like, well, I got this open bite case that you might be interested in. So sure enough, I waited for the journal to come out, and it came out, and look what he was using. He was putting in the TADS buccal lingually, and then putting in the Invisalign on top, and then putting sling elastics over it. And so now we start to see this pool. Now we have a sample size of 7, because I could take this case and then calculate how many aligners he used, how long the treatment time was, and then add to this pool. Okay? So if I were to then summarize what did I learn from my assessment of the 33 open bite cases, I would say that the most popular formula, if you will, for the doctors that were successful in their treatment was the following. A lot of them used anterior attachments to grab onto the teeth, to extrude the teeth. We saw that earlier in the previous presentations. A lot of doctors were using IPR to create space to be able to retract the front teeth. If the patient had class 2 and class 3, they were running class 2 and class 3 elastics in order to auto-rotate the mandible forward to close the open bite. And then finally, the use of TADS with the sling elastics to intrude the posterior. Those were by far the most popular approach. And then I didn't look at the molar intrusion, actually. So in listening to the earlier presentation, I realized that maybe I should have looked at that as well. So that could be up there. I don't know. And then what was not as popular was bicuspid extractions, triangular elastics, vertical elastics, braces with elastics. Not that they couldn't become more popular in the future, but again, they just didn't make the list for 2012 and 2014. So what happened? Well, I did not do this study before I actually treated my patient. Maybe I should have. But I told her if she decided to do the surgery, go get the surgery, and then just come see me afterwards, and I'll be happy to finish up the case with the aligners. And so she did. She had insurance to cover the surgery. She didn't want to wait 2.5 years for her treatment. So she went and got surgery without braces. The surgeon put a bar in there, and afterwards she came back and voila, the open bite was closed. Okay, and now she just had spaces in the bottom and open bite on the left a little bit class 2 on the left. And from here, it was like, well, perfect. I just do Invisalign from here, not a big deal. So we went and ordered Invisalign for her. We had the elastic hooks built into the aligners to get the class 2 on the left side corrected, and there she is afterwards. It's not a particularly difficult case to treat at that point, but we finished it, and it took 9 months, which was nice. And the best part, I think, was if you look at the roots, they're still there. At least what's left, that's always good. Because that was the main concern, right? It's a special circumstance that helps us to be more careful as to how long we want the treatment to last. And then I just happened to see her 1 year afterwards and snapped a photo, and there she is. Okay, so that's now, I picked something that wasn't even on the list. Right? Out of the 33 sample, there was none of them that were surgery first. So what happened? Because, the first orthodontist, the other orthodontist anyways, offered TADS and aligners to the patient, and we know that it can work very nicely, yet she chose not to do it. Why is that? And I think it's this. I think it's because the doctor said to her, it's going to take 2.5 years, and we're only going to get 80% of the result. So that's like taking a new path that's going to take a really long time, and then not really getting there, and then being able to enjoy the view from afar. I think the patient would have gone for it had the doctor had more information to give her greater confidence. Had the doctor shown, here's some examples of what TADS and Invisalign could look like, maybe that would have worked better. Maybe if he had better data about how long the treatment take would actually take. It's like, yes, we've got a sample of, I don't know, right now it's only 6, but the average treatment time of those was and I looked it up, 25 months for the 6, so it's not 30 months, it's 25. Maybe that would have helped, I don't know. But that's my guessing. In reality, I also thought that what the surgeon offered was a gondola ride to the top, and then all I had to do was just kind of walk her into the end. So I understand that there are some advantages of surgery. So, to wrap this up, what can we do next? I think there's a lot of work needed. I'm just painting for you a picture of how we might go about doing this. I think if we start with success, at least it'll give us something to aspire to. But what needs to be done is someone needs to do the hard work to actually quantify these measurements. Someone needs to go and trace the records and say, well, okay, that's nice, you have 25 successful cases, but how many degrees of torque can you achieve? How many millimeters of open bite can you accomplish? What's the standard deviation, so that as clinicians we can say with greater confidence, yes, with Invisalign you can get this amount of open bite closure. With this aligner system, that's a different aligner system, you can expect this amount of open bite correction, and so on and so forth. We need to be more specific and say, with this type of system you can get this amount of class 2 correction. With this type of system, you can get this amount of class 3 correction. And have details as how you go about doing it. And someone needs to go in there and start looking at things like deep bite, how much deep bite closure you can get. Someone needs to go in there and look at the different types of deep bite correction, which I'll talk about tomorrow in the workshop if those of you are interested. And the good news is that there's money available as well. So Invisalign still has the research award program. For this year, it's $350,000 that's available as a total pool. You can go online to, if you're associated with a university, you could look at their application process. So I'm just promoting this just because of my past with that. And if you are interested in what I mentioned about the coaching, this is a book that was written by one of my professors, Jane Creswell. She started the coaching network at IBM, which today has over 500 members, and they're used to coach executives, managers, directors at IBM, and that allows them to move forward. And with that, I'm out of time, and thank you very much for your attention.